Good evening and welcome. I'm John. I'm the event director at Literati Bookstore. We're pleased to welcome Abdul Al-Sayed and Micah Johnson in support of Medicare for All, a Citizen's Guide this evening. First, a quick overview of webinars for those of you who are joining us late. The chat is closed, but you might want to keep the chat window open this evening, as I will be dropping links to purchase Medicare for All Citizens Guide from Literati Bookstore. And if you are watching us later on YouTube, there is always a link to purchase books right in the description below. If you're watching live, of course, you can submit questions for the Q&A using the Q&A feature available to you at any time, and I will read a selection of those questions at the conclusion of the conversation. As a reminder, if you live in Southeast Michigan, you can shop for more books at literatibookstore.com for curbside pickup. And if you live anywhere in the United States, you can also shop to have them shipped to you where you live. In lieu of a book purchase, we'd also ask that you consider a $5 donation to sustain our virtual programming. Whether you'd like to think of that as this week's or this month's or this year's subscription to our programming, you can make donations at literatibookstore.com/donation. Otherwise, we simply thank you for your attendance this evening or this morning or this afternoon, depending on where and when in the world you may be joining us from. And now I'll introduce the authors of tonight's book. Abdul Al-Sayed is a physician, epidemiologist, public health expert, and progressive activist. He rebuilt Detroit's health department after the city's bankruptcy as the youngest big city health commissioner in a major U.S. city. He ran for governor of Michigan in 2018 on a state-level single-payer platform in a bid endorsed by Senator Bernie Sanders, Congresswoman Alexandria Ocasio-Cortez, The Nation, and Current Affairs. He holds a doctorate in public health from the University of Oxford, where he was a Rhodes Scholar, a medical degree from Columbia University. Micah Johnson is a physician and healthcare researcher, writer, and policy advisor. He served as a health policy fellow in the U.S. House of Representatives and has advised presidential campaigns on healthcare reform. He holds a degree in philosophy, politics, and economics from the University of Oxford, where he was a Rhodes Scholar, and he received his MD from Harvard Medical School. He is currently a resident physician in internal medicine at Brigham and Women's Hospital in Boston, Massachusetts. They can't hear you, but through the power of the internet, they can certainly sense you. So please join me in welcoming Abdul Al-Sayed and Micah Johnson into your living rooms.
John, thank you so much. It's a privilege to be here with you all. I'm a hometown guy, so always excited to be supporting Literati and in Ann Arbor books, and really excited to be talking about Medicare for All with my co-host, the indomitable Micah Johnson. My my co-host, my co-author, the indomitable Micah Johnson. I'll just give you a reason why I was interested in writing this book, and I'll hand it over to Micah. We've heard a lot about Medicare for All, but usually in the context of a political conversation. And there's a challenge with political conversations, as I've learned firsthand. Which is that we don't necessarily dig into the policy, and sometimes it becomes impersonal. We're less focused on the ways in which a particular policy might shape the life of everyday folks in places across this country and in Michigan. And we wanted to take this conversation out of the political and make it personal again, because that's where any conversation about healthcare has to start and end. And so we wanted to create a book that would allow us to reintroduce this conversation in that particular way. We were really excited about that opportunity and hope that we've connected with that outcome. And I could think of no better person to write that with than with Micah. I got to know Micah actually in Oxford way back in would have been 2014 or so. Was immediately taken by the combination of intellect and earnestness about how policy ought to change, and got to know him even better when I ran for governor, and he helped to put together our Medicare plan, a single payer plan for Michigan. And so, I could think of no better person than Micah to co-author this book with. And I was really excited when together we decided that we would do this. And 2 years on, here we are. So would love to just introduce Micah Johnson, my co-author.
Yes. Thanks, Abdul, for the introduction. Thanks, John and Literati for hosting. I live in Boston, but at the end of 2019, when I was traveling, interviewing at hospitals, I got to stay in Ann Arbor, went into Literati, and actually worked on some of the last chapters of the book from the bookstore. So really glad to be able to do the event with now that the book is finished. And the reason that I really was excited about this is I saw, even in medical school, just the difference between the content of our political conversation about healthcare and the experience that patients and doctors were having every day. And so much of the political conversation has been focused on, let's try to get more people insurance, obviously, which is great. But here in Massachusetts, almost everyone has insurance and people are still struggling. People still can't afford their medications. People will still go bankrupt when they get sick and go into the hospital. So part of what got me excited, first working with Abdul on the campaign and then this book, is let's really take a step back and ask not what today's political moment offers us, but what do patients really need? So I hope that tonight we can have the chance to have the back and forth. We'll have plenty of time for questions. We want to have a conversation about what would it really mean to try to tackle our healthcare problems at the root. So again, thanks so much for having us.
I want to take the opportunity just to read a bit from the introduction of the book to set the context about where the conversation about Medicare for All fits within our broader public debate and where it goes. So this is just beginning in the introduction. The genius of the American experiment is that it set out to establish a nation founded on the will of the people. That aspiration is framed best in the US Constitution, a prescient document whose preamble sets out a series of intents for a new system of government. One of those intents is to, quote unquote, promote the general welfare. We've long struggled to meet the aspirations framed in that document, but this one is particularly challenging. Although it's difficult to get an accurate assessment of what the state of the general welfare was when those words were written in 1787, it's safe to say that it was far worse than it is now. Best estimates suggest that the life expectancy for white men was 38 years. Such figures were sparsely recorded for women who lacked all but the most basic rights in that time. They also leave out the nearly 700,000 Black Americans living in the United States, over 90% of whom were enslaved. The inhumane circumstances of their lives means that death and disease were certainly far more common among them. And even today, their descendants continue to suffer from a life expectancy that is nearly 4 years shorter. We're tempted to think that with a life expectancy of 38, people just drop dead in the prime of life. But in fact, life expectancy is an average, dragged down by deaths in infancy and early childhood. In 1787, nearly 1 in 5 babies died before their first birthday. Another 1 in 5 died before the age of 5. That's largely because the germ theory of disease was still a century in the future. And in the era of modern medicine that it ushered in was even further away. The most common causes of death were all infectious diseases: pneumonia, tuberculosis, cholera, dysentery, and smallpox. These infections have a predilection for the young, whose immune systems aren't yet fully developed. Without modern vaccines or antibiotics, what little medicine was practiced was done at home. Surgeries, from minor tooth extraction to limb amputation, were performed without anesthesia and without sterile equipment. Much of it was deadly, none of it was particularly effective. And yet, as early as 1798, the Fifth Congress passed and President John Adams signed an early attempt by the fledgling republic to promote the general welfare, an act for the relief of sick and disabled seamen. At that time, international trade was vital to the well-being of the United States, although being a sailor was a particularly dangerous trade. To protect its merchant marine, Congress passed the law creating a system of government-run hospitals for seamen funded by a mandatory tax on their earnings. As science advanced through the 19th and 20th centuries, American government acted as a catalyst to convert new knowledge into broad improvements in general welfare, improving sanitation, putting fluoride in drinking water, ensuring widespread vaccination, funding new hospital construction, and guaranteeing health insurance for senior citizens. Modern healthcare has developed tools that humanity couldn't have imagined in 1787, from vaccines and antibiotics to robotic surgery and targeted immunotherapy. Because of these advances and so many others, nearly 250 years after the people of the United States ordained and established the Constitution, American life expectancy has more than doubled. And yet, perhaps by the standard of our time and the power and wealth of our country, we are yet failing to promote the general welfare. Life expectancy in the United States is nearly 6 years shorter than in Japan, the longest lived country in the world. American infant mortality ranks 55th in the world, and American health disparities by race and socioeconomic status are among the world's steepest. Perhaps worse, life expectancy has stagnated, even falling for 3 straight years between 2015 and 2017. Rather than the infectious diseases of the past, the diseases with a predilection for the young today are diseases of despair, drug overdose, alcohol misuse, and death by suicide. For the population at large, cancer and heart disease are the top killers. I wanted to give this context because I think it frames where we're headed in terms of this discussion about what problems we need to solve. And I'll leave it to Micah to speak a little bit more about the specific topic of the book.
So I'll read a short encapsulation of what we're actually talking about. What is Medicare for All? And then we'll jump into some of the meat here. Medicare for All is a proposal to create a single publicly funded insurance plan that provides comprehensive healthcare coverage to all Americans. Medicare for All would be an American version of a single-payer health insurance system, with one payer, Medicare, funding healthcare for the entire population. Medicare for All would be an enhanced version of the traditional Medicare program that tens of millions of seniors rely on today. Other Americans would transition from their current insurance to Medicare for All, including people who currently have employer-based insurance, Medicaid, or private Medicare Advantage plans. People who are currently uninsured would also gain coverage through Medicare for All. Much like Medicare or Social Security today, Medicare for All would not be an opt-in or opt-out program. Everyone would be covered. An important feature is that private hospitals and doctors would remain private under Medicare for All. This distinguishes Medicare for All from so-called socialized medicine systems like the VA in the United States or the National Health Service in the United Kingdom, where the government owns most of the hospitals and employs most clinicians directly. Medicare for All would be more like the Canadian healthcare system, where the payment system is public, but the delivery system of doctors and hospitals remains private. In short, Medicare for All would change how we pay for care, not who provides care. So I think that sets us off for what we're really talking about this evening. And part of what we do in the book is diagnosing what's wrong in the current system and thinking about how Medicare for All tackles those specific issues. So Abdul, maybe you can keep us going with what are the problems in the healthcare system as it stands that are trying to be solved with reforms like Medicare for All?
Yeah, let me give a couple of points of that, but I want to just take people into this system for a second, because I think it's very opaque for folks who don't spend much time in it, and it doesn't exactly make sense. And I want to use an analogy first to a grocery store. Let's say you want to go to a grocery store, and because it's in Arbor, let's say you want to go to Zingerman's, okay? And you decide that you want to buy a loaf of sourdough, and that loaf of sourdough you take to the cashier at Zingerman's. The cashier tells you how much it costs. You then hand over a credit card or some cash, and you pay for that, right? That's what being a customer is. You choose the product that you want, and then you take it to a seller. The seller exchanges that product for money. Now, I want us to apply that same analogy to the healthcare system for a second, because I think it's really helpful to understand some of the inefficiencies in the system and what those problems are. In our system, right, you have healthcare providers, the doctors and the clinics and the hospitals that you go to for care. And then you have payers or health insurers. These are the people that you pay money to every 2 weeks or month, you and your employer, if you're lucky enough to have employer sponsored healthcare. So that if you, right, who are here, are to need care with the provider, right, that this insurance will pay for you. And if you think about that, right, you get sick, you go to the doctor then bills you, but it doesn't bill you, they bill your insurance, who then pays the provider. If you think about it, right, in that same analogy, you're not the customer, you're the reason a financial transaction is happening, which makes you more the product, right? And because there are 900 of these insurers, right, and thousands of these folks, they have to have a system to be able to crosstalk, which introduces a tremendous amount of overhead in the healthcare system. And right, they're able to set prices in ways that are really, really opaque. And because both of them want to make more money, the prices generally go up, which leads to the first problem, which is that healthcare is too expensive. The second is that there's really no incentive to protect you from getting sick in the first place, right? Because in the end, you're a reason why a financial transaction happens. And so we don't spend very much money on prevention in our system. If you think about the way the system operates, right? You are not really secure in terms of knowing that the system's going to be there, because, well, if you lose your job, you lose your health insurance, has happened to 15 million people this year. And even then, even if you keep your health insurance, the insurers have devised systems to hit you on the back end of the costs of healthcare, almost taking out an insurance policy on their own profits in the forms of deductibles. It's the reason why healthcare accounts for 67% of all personal bankruptcies in the United States. And then, right, beyond that, right, like the quality of our care, is not as high as it is in other contexts, simply because really, well, not simply because, many complex reasons. One of them is because we have such a tiered system. And then the last point, right, is even the way that we pay for that most expensive healthcare in the world is tiered. And so, you know, if you are a high income individual, generally you're paying less as a proportion of your overall income than a poor individual. And 10% of people in our entire system are locked out of the system to begin with. Micah, what are some of the others that I missed?
No, I mean, that's right on point. And to keep going with some of those, the points that you made, one is, I think there's a lot of punditry about why healthcare costs are high, you know, but a lot of that is a data-free zone. And part of what we do in the book is we drill down to try to uncover what the actual reasons are. So first, at a very basic level, there are two reasons healthcare costs theoretically might be high. One is maybe Americans are just using more healthcare. Maybe we're going to the doctor more and getting more tests and getting more surgeries. Or it's because when we get those doctor's visits and get those tests, we're just charged more for them. So you can't just settle that issue from the armchair. You have to look at the data. And it turns out it's very clear Americans don't get more healthcare than people do in other countries. We're just charged more for it. So we have less doctor's visits than people do in other countries. We have less hospital beds and less hospital visits. So this idea that somehow Americans are overusing the healthcare system is a bit of a red herring. It really just, like we often do in this country, we try to blame individuals for systemic problems. The problem isn't that Americans are trying to get too much healthcare. It's that we're being charged far more every time that we do get healthcare. And, you know, to think about this at a hospital level. So what does it mean that our prices are higher? Well, here's what it means in the hospital that I work at. It's a bizarre medical billing system where the so-called price for a procedure, whether it's a heart surgery or an MRI, it varies enormously on what kind of insurance the patient has. So it could vary by a factor of 2, a factor of 5, even a factor of 10, whether you're on Medicare, Medicaid, or private insurance. And it turns out that the best deals are in Medicare and Medicaid, which kind of flips this whole thing on its head, where people often think that, well, what the private sector can do, it can keep prices down. But in healthcare, that's just not the case. Medicare and Medicaid get much better prices than private insurance does. And it's for a very simple reason. It's bargaining leverage. When Abdul explains how the providers and the payers negotiate, if there's 900 insurance companies, it's really hard to say no to a hospital. If you're the only hospital in town, it's really hard for the insurance company to negotiate with you. But if you're Medicare and you insure 40 million people, you can get a great price. So the reasons that Medicare for All actually saves money compared to the current system, one, you have much more bargaining leverage. You can actually get good deals for Americans by pooling together the resources and the bargaining power. And second, you simplify the system. Instead of having hundreds, and even in single hospital systems, can have thousands of employees whose job is to do billing with insurance companies. You streamline the system to decrease costs. And what that really means is that we can afford to cover everyone under Medicare for All for similar or less costs than the current system.
The other part of this that we do talk about is the politics of it. And I said that, you know, in the top, we wanted to make this a personal conversation. But the personal becomes political when you realize that we're living in a system that is as bad as it is. And we have a breakdown of the various folks who we think become a part of the organizing coalition for Medicare for All. Let me step back and explain what I mean by that. Health insurance corporations in 2020, they made bumper profits off the pandemic. And they made those profits because the elective procedures that are their most costly line item, those got canceled when the pandemic hit. And so, you know, you've got major corporations that almost doubled their profit in Q2. They took that money, right, and invested it mainly, right, in payouts, right, to the folks who make money when they make money. And then also spent a whole lot of it lobbying government, right, $151 million. And then spent a lot of it actually on advertisements, right, to dissuade the public against supporting Medicare for All. And then after that, the public option after Joe Biden was nominated and then finally elected. And they are doing this to protect their profits. They employ 845 lobbyists, the health insurance industry does alone. That's almost 2 lobbyists per member of Congress. And what they've really been focused on is fundamentally their profit, just like any major corporation is focused on its profit. And the way that they win is to advertise and to capture the political class. The way that we win Medicare for All in the future, if it's to happen, is because we organize against it. We have a whole chapter called Organizing versus Advertising. And the questions become, how do we build a coalition of people who decide that they are going to get up off the sidelines and be a part of this fight for Medicare for All, founded in their own personal experiences? And, we talk in this book about a young woman named, I'm completely blanking on her name.
Lisa.
Lisa, thank you. Lisa Cardilla. Lisa's an amazing human being. She had the unfortunate circumstance of having gone through a very uncommon form of heart attack at 36 years old. That was 3 years after her husband had a brain tumor removed. And they were insured through her husband's employer. They thought they had great insurance until, of course, they had to use it. And they had to go, and their friends and family had to throw a fundraiser. They had to have a GoFundMe to pay their deductibles. And they're still making decisions about how to pay those deductibles every year. But you think about somebody who goes through an experience like that, and you ask, well, what are you willing to do to change the system? And that's what creates organizers. It's the personal becomes political. And there are a few major players we think are really going to be critical. There are, of course, folks who've been there all along. Folks like the nurses have been there all along. And some other unions have been there right there with them. But for the most part, right, there are some swing groups. One of them is doctors. And I want to talk about doctors for a second here, because I think they're a really, really important category of folks. Oftentimes we think about doctors as being enemies to single payer healthcare, well, because for most of history they have been. But the very foundation of the business of medicine has changed. And it has changed because of the way that corporatized healthcare has dominated the system. It used to be back in the day that doctors used to work for other doctors. They used to either open up their own practice or go buy into a practice. They'd work their way up and then become owners of a business. And the AMA was their guild, right? A guild is the way you organize a set of businesses, whereas a union is the way you organize a set of workers. And for the most part, they had sought to kill Medicare for All because they thought it would reduce their earnings. But doctors today aren't really the ones who profit most off of the frustrations of the healthcare system. They tend to be the CEOs who tend to have MBAs instead of MDs. And what's happened now is because these large healthcare systems have the capacity to negotiate better reimbursements than the smaller guys get bought up. And so it's very hard to start your own practice now. In fact, most practices are just selling to the big guys because they can't compete anymore. And what's happened now is that doctors are, in effect, workers at major corporations rather than owners of their own small businesses. And that has fundamentally changed the economics of healthcare for them and changed their preferences. In fact, 2018 was the first year that the median doctor didn't work for another doctor. And it was also the year that the median doctor supported single payer healthcare. And I think those two things go hand in hand. And so we see the future changing because this system is becoming unsustainable for middle income people and becoming unsustainable for doctors who retain a large proportion of people's attention when it comes to the future of healthcare. And it comes to what we ought to be doing. People trust their doctors. And I think it's really important for us to understand how these winds are changing and why we need to be a part of it. And so one of the reasons we wrote this book is because oftentimes when the world is working a certain way, it's hard to see how the system created around you shapes your own experience of healthcare. And our hope with this book was to make that less opaque and make it more lucid and clear, so you could see exactly how your own health care experience maps to the problems with our healthcare system and the potential for the solution.
And just to pick up, I think what's going on with COVID has accelerated a lot of the trends that Abdul just described, where there's no doubt that the biggest opponent to health reforms like Medicare for All is the healthcare industry. There's just no question about that. Insurance companies, pharmaceutical companies, and many of the monopoly hospitals are very wealthy and very powerful. So the question is, what does it take to win? And there's already, for over the last decade, this trend of Abdul described for doctors in particular, flipping on this issue. And I think with the pandemic, we see even more this focus on healthcare workers and not healthcare corporations. So you have nurses and pharmacists and technologists and environmental service workers all banding together with this recognition that their interests are not always the same as their employers. When you have folks who are lacking PPE in the middle of the pandemic, you suddenly have healthcare workers, and there are tens of millions of them in the country, starting to get more of a cohesive political voice. And I think that could really change the politics around healthcare, where now if the focus on healthcare politics is about the people who are actually working on the front lines, and the COVID pandemic has really opened up that opportunity with all the attention put there, I think that opens up space for having a better conversation about healthcare. And the other thing that COVID is doing is that in kind of invisible but critical ways, it's changed the way that we're even talking about healthcare in this country, where with Abdul's analogy about going to buy the bread, that's kind of how our politicians have been talking about healthcare for the last 40 years, been talking about it like a consumer product. And even the Affordable Care Act, we're kind of treating healthcare like a consumer product. The whole idea is we're creating a new, they're even called the marketplaces, where you buy Affordable Care Act insurance. You try to get companies to compete, and you can buy it in the marketplace. We're not talking about that with COVID. We're saying this is a vaccine that everyone needs because they're a human being and they deserve it. And I think there's also an opening to reframe the conversation about healthcare as a human right instead of as a consumer product. So I think the ways that COVID is affecting the system, more than ever, are changing the conversation in ways that can make reforms like Medicare for All more likely and more possible.
The other, couple of constituencies that we think will really start to shift on this are seniors and labor. And when it comes to seniors, right, for a long time, they've been told that Medicare for All would simply cut the Medicare pie into smaller and smaller pieces. When actually, if you think about the way that insurance works, is that you've got a risk pool. And the more folks you have in the risk pool who put money in and take less money out, the healthier that risk pool is. And that's exactly what Medicare for All would do. Right now, we're having conversations about the long-term viability of Medicare because right now the risk pool is rather unhealthy. We only cover people after the age of 65, when of course aging starts to take its toll. But if we were able to focus on investing Medicare toward everyone, we would be able to make that risk pool so much more sustainable. And then the other group are labor, right? And for a long time, labor has been told that, well, they would lose their platinum status healthcare. The problem is that how much do you think that costs? I was interviewed by a gentleman who owns a business in Canada where he also employs people in the United States. And he said, basically, for every US employee that I have to hire, it's like paying a 25% tax above and beyond. And we forget, right, that would have been money in people's pockets if it wasn't money in the health insurers' pockets. And then the last constituency that I think really will move on this is business, for exactly that same reason. If you're a small business in the country, one of the hardest things you have to think about is paying for healthcare for your employees. If you're a big business, you may be self-insured, but that program is extremely expensive. And when I ran for governor in Michigan, we estimated that GM would save 20% off the top of their healthcare costs immediately if we passed single payer. And guess what? They'd be paying a sizable proportion of the overall cost. Even yet and still, they would be saving money. And so, even if you were able to pass a progressive tax linked to paying for healthcare and corporations paid their fair share, they still end up paying less. And so business really ought to be on the side of this. The question is, are you able to cleave their interests from the interests of other folks who sit on chambers of commerce with them, like the insurers and the hospital industry? We'd love to answer any questions if folks have them. So please make sure to put them in the box or pitch them our way.
Yeah, if you have questions, please feel free to submit them using the Q&A feature. Obviously, the chat is closed, but you can use the Q&A feature to submit questions. Gentlemen, I have maybe a couple questions. So thinking about this book as sort of thinking about what it would look like, and sort of getting past sort of the partisan stuff and the spin that has happened with policy since it became well known and popular, and to what it would actually look like. I guess I'm thinking, and I'm sorry if this is relitigating something that you go through a lot and answer a lot, but hearing you talk, I'm thinking about, three instances of getting, like, how do we get past the sort of like a mental block we might have about what this policy would look like. So I'm wondering, like, what would it look like for someone who, say, is employed but doesn't get insurance to their employer? They're youngish, maybe they had bronze or silver plan, and premiums got higher and higher, and then they decided, I'm going to get like an HSA or an ISA or some sort of like catastrophic-esque plan and just ride with it, and whatever, we'll see what happens. They don't have anything terribly chronic happening right now. They're not in a GoFundMe situation. What does it look like for them day one under Medicare for All? Two, someone who is gainfully employed and has insurance through their employer, their significant other is thus covered. They have someone under them who they have a child, the child sees a pediatrician, all of that sort of, it's all working for them. Everything is sort of already set up and streamlined. What for them beyond, like, I guess, like a prima facie ethical imperative, brings them to want to hop on board and join a pretty large chorus of people who already support this policy. And then for three, I think the other thing people have difficulty thinking past is, I work in health insurance. Say I work in health insurance as like a marketer or sales or something like that. I'm not one of the people who's sort of at the top of the wealth extraction practices of health insurance, but it's a huge industry, right? There's, you said 900 insurers, they employ thousands. And I think one of the sticking blocks, and I know this is a party sticking block, is what do you do with this huge industry? How do you gradually replace it? So sorry if this is meaty, but in those three instances, sort of thinking about what is the reality for those three individuals under Medicare for All. I think in the first instance, probably pretty apparent, but I'm just curious to hear, what does it look like for those people viscerally, in terms of why they would want to be a part of a movement for this policy?
I'll jump in the first couple. Look, their experience would be exactly the same. There'd be a little bit of money taken off of each paycheck, and it wouldn't really matter who they were. I mean, if they were 1099 employees, they'd be paying some money in taxes in their 1099 employee. The important thing is that, I assume that first individual, that younger person who's just getting started in life, their income is probably lower, and so they're paying less, right, as a function of that. But their experience of getting healthcare is exactly the same. They get to see any doctor that they want. They don't have to worry about in-network or out-of-network, that their healthcare is going to be paid for, and they have freedom. And the important point here about the second couple is that, they assume often, if they're healthy, that their healthcare is going to be paid for, that their insurance, right, the operative term in insurance is sure, that it's going to be there for them, right? But we already told you Lisa's story, and she thought she was in the same boat. Until, of course, both she and her husband had to use it. And then there was a deductible, which, just for folks who don't understand what a deductible is a paywall that you have to pay in order to get access to the insurance product that you already paid for every 2 weeks or every month, right? And that deductible for an average family of four is $3,655 a year. So you have to pay that money to the insurer in order to unlock the money you already paid for. That's money coming out of your pocket. And if that median family, right, if a median family of four is making $69,000, that $3,600 paywall is more than a single paycheck every 2 weeks, right? So this is a lost paycheck, right? And most families can't sustain a lost paycheck. And so the point here is that all of them have a level of security in their healthcare access that they are able to pay what they can for, right? But that will be consistently there for them, independent of their circumstance. And that's the beautiful thing, right? Because at one point, that couple, they were that kid, right? And that important question of where you are in your life, right? And the life course of individuals, and knowing that healthcare is there for you, independent of where you are in your life course, that really is the benefit, right? The lived experience of Medicare for all. And that's worth fighting for no matter who you are, because you can't take for granted that health insurance is going to be there for you when you need it most.
And I'll pick up there. And I think the second case that you asked about is critical. And that's where a lot of the political conversation has been focused on. What about people who have, so-called good private health insurance? And I think one of the most important stories in healthcare over the last 10 years, while we've been having these really charged political debates about the Obamacare marketplaces and whether we're going to expand Medicaid or not in different states, kind of very quietly, the employer-based health insurance market, where 150 million Americans get their insurance, has eroded. The deductibles have doubled. The premiums are up 50% over the last 10 years, far faster than wages. So we now have this situation where even people who have the quote unquote best health insurance that America has to offer are starting to really get hurt by the system. And that comes whether it's the deductible, whether it's the narrow network, whether it's just the insurance company looking at your claim and just telling you no. So we have one of the, a great quote that we found in researching the book is from one of the architects of Medicare, who said that in America, only when the broad middle class is being hurt do we turn to universal programs addressed to all of our citizens. And I think over the last 10 years, we might be there on healthcare. The most common form of insurance for the middle class, employer-based insurance, is not what it used to be. And people are really getting hurt by it. And I think that also changes the politics around the issue quite a bit. And the other piece to mention here is something that doesn't get mentioned in the talking head conversation about this, but that I see every day dealing with patients, is the mind-numbing complexity of the system. And I think one of the ways that people's experience would change under Medicare for All is it would be far simpler. And like policy wonks don't usually care about that, but when you poll Americans who support Medicare for All about what they think is most important in a national health plan, number one, they say it should cover everyone. Great. But number two is that it should simplify the healthcare system. That actually ranks above things like eliminating deductibles and decreasing out-of-pocket costs. It's just such a nightmare to navigate the healthcare system. And there's research that we cite in the book where it's not just annoying, it actually makes people get worse care, where there's just so much sludge that you have to fight through to get healthcare in this country. And part of what Medicare for All does is it streamlines that. You can find the doctors and hospitals and medicines that you need to take, and you can take them. So I think there's an economic interest, because you fund Medicare for All with progressive taxes, it just turns out that the vast majority of people would pay less for Medicare for All than they do for the current system. But you also change the experience of healthcare. And that's one of the things that I'm most passionate about with this, where what people are actually experiencing in their day-to-day, going to see their doctors and trying to get treatment for their conditions, I think would actually be significantly better after this reform.
The other question you asked was an important one about the experience of somebody who works in health insurance.
Sure, yeah.
I met a woman when I was on the campaign trail who came up to me and said, I used to work for the state's biggest health insurer, and I quit the day that I was told that I had to deny a woman with breast cancer coverage for her care, even though it was going to put her in bankruptcy. And that day, I decided that I was going to go back to school and become a nurse because I wanted to be someone who took care of these people instead of who denied them health coverage. So she went back to school and became a nurse and takes care of people with breast cancer. I mean, there is a profound moral disappointment, frustration, disgust that I think a lot of people have with the business model that creates this sludge for a reason, right? She was one of those sludge makers. Her job was to be that person you finally get to at the end of some 1-800 call, and who tells you that they're going to run it up the chain, who then gets back to you, tells you that you need to produce one more piece of paperwork, that then tells you that they're not actually going to cover your care, and that you're going to go bankrupt because you got breast cancer.
Mm-hmm.
I mean, and so, yes, there are going to be changes, structural changes, but I'll just say this. In our country right now, 10% of Americans are locked out of the healthcare system, 10%. So think about, we already have a shortage in a number of the most important areas of care. What would it mean to include 10% more people in healthcare? There are going to be a ton of jobs that are created that we're going to need, right? Whether it's in nursing or it's in medical tech work or it's physicians. And so, yes, over time, there's going to be a shift, but in time, this is going to make a lot more jobs than it loses. And they're going to be healthcare jobs that don't involve denying people healthcare. Instead of they involve providing people healthcare, which is, of course, why all of us get into this work in the first place.
And is this transition envisioned sort of like, in terms of policy, I'm just curious, and we do have one audience question I want to get to, but is that transition envisioned as sort of something akin to like a New Deal type kind of massive shift in training and sort of very quickly scaling up these kinds of jobs and positions as certain aspects of healthcare are nationalized? Is it, do people talk about it in terms of like year segments? I'm just curious what the thinkers think and the planners.
We talk a little bit about this in the book, and it really, there's a policy timeline and then there's a political timeline, and you have to think about both of them. Either way, there's going to have to be a massive investment in jobs training and investment. Like, this should be a just transition. It doesn't mean that people who might lose their jobs as a function of the changing system should just be left out to dry, right? Like, we need to make sure that there is a really great opportunity for them on the back end of this. And that's thoughtfully done and engaged in. And yes, it would require job retraining and ideally paid job retraining, that you get paid, right, to go back, retrain, and get another job on the back end of this. Micah, I'd love to hear your perspective on it.
Yeah, I think there's the insurance side, and then there's the jobs and infrastructure side. On the insurance side, just very specifically in the Medicare for all bills in the House, in the Senate, there would be a certain period over the course of some number of years, 2 years, 4 years, where different groups would be moved over piece by piece into the Medicare for all system. So that's sort of the practical piece of it. I think the other part of what you're getting at is making public investments in healthcare, because I do think that the conversation about healthcare needs to be broader than insurance. A lot of the root causes of why the system is the way it is because of the insurance system and the way that we pay for healthcare. But we should be supplementing the insurance reforms with big public investments in community health centers and in nurse practitioners, physician's assistants, primary care doctors. And I think, one thing we haven't talked about is what's possible in the current Congress. And, I think these things are so popular, to give better funding to community health centers or to train more nurses and doctors to work in primary care. These things are ridiculously popular because people know that they're needed. And, I think when we think about, what are stepstones to get us to making healthcare a human right, I think some things that we can be doing right now is investing in the people and the infrastructure that we're going to need on that day when we finally do make healthcare a right.
And that, I think, leads nicely to a question we do have from a viewer, and maybe also touches on, Micah, some things you and I were talking about before we went live. This viewer writes in, while Medicare for All is one way we can remove barriers to healthcare, what other ways do you believe that we can better manage population's health, i.e. transportation, pollution, school nutrition?
So, there's a ton of things that we need to do to get population health right. And I'll be honest with you, I'm a public health person. I don't come to this conversation because I'm enthralled by healthcare policy. But actually, I sort of see healthcare policy as being a fundamental impediment to smart public health policy. Because in this country, we do it backwards. We assume that healthcare is the big dominant question, and then public health sits over here in some like little corner piece. But actually, right, smart healthcare is just a bigger part right? A smaller part of a bigger question about how we keep people healthy in the first place. And part of that is about incentives. And Medicare for All is critical to getting the incentives right. Right now, you have 900 plus health insurers, none of whom have a real incentive to promote any sort of prevention because of the churn in the system, meaning that people are likely to be on your healthcare plans of today, but as you talked about, John, to jump onto some other healthcare plan tomorrow. So your incentive to invest in something that's going to pan out over the long term is decimated. Under Medicare for All, the government is your insurer today. It was insurer yesterday, and it's going to be in your insurer tomorrow. And so there's a lot more incentive to really investing big picture on promoting health in the long term, and to put real dollars toward that. And so, yeah, I agree. Medicare for All is one thing we need to do, but it is one of the most important things that we need to do to be able to unlock the system for broader level investment in population health. We spoke to a former Obama, very high up Obama healthcare official, and this is the point that she made. She said, look, at the end of the day, whatever the political wins for Medicare for All are, the most important thing we can do is take health care and minimize that conversation within the broader conversation about population health. And it's not until we think about healthcare as part of what we do for population health, rather than population health being what we do for healthcare, that we're going to get it right in this country. And I think she's spot on. And this is the big reason why I think anything we do has to start with getting this healthcare problem out of the way. Because let's not forget, we spend 18 cents out of every dollar spent in the entire economy on healthcare. Right? That's a lot of money, bigger line item than almost anything else. And if we can't subjugate that money to keeping people healthy rather than to providing them care when they get sick, we're not going to get it right.
Yeah. And my take on that is that there's some things we need to do to make people healthier that are they're outside of healthcare. And I think what healthcare advocates and activists can do is to be allies, whether it's in housing, racial justice, criminal justice. All of those things are critical to our health. Then I think within healthcare, there's a lot of things that we do in healthcare that make everything else worse. So people say, oh, well, that's not a healthcare problem, it's a housing problem, or that's a food security problem. But healthcare costs are hitting families so hard that when we do the studies, we see that healthcare costs are putting 9 million people into poverty every year, or healthcare costs are causing people to lose their homes or to go without food. And then on the flip side, we can study what happens when people get good health insurance. So what happens in a state when you expand Medicaid? And you see that evictions go down, food security gets better, employment gets better. So the healthcare system is such an albatross on the economy and on so many families' kitchen table budgets that by offloading those costs, you can actually make a big difference in just the overall material conditions that people are living in. So for me, it's a both and, where there are so many things that we need to be allies on. And a lot of the same people and groups that are organizing around healthcare are organizing on these other issues. And we also need to be clear that healthcare is just making so much else in our country harder than it needs to be. And I think we can unlock a lot of that by doing a reform like Medicare for All.
We've got one more, again, the audience comment, and then I think it can transition us into one last question. The comment is from someone who writes in that they've practiced medicine for 35 years. And besides destroying unions and thus vastly hammering employee rights and benefits, Reagan also used his Justice Department to go after doctors. There's a law passed in 1946 called the McCarran-Ferguson Act that exempts insurance industry from federal antitrust law. In the 80s, with the support of the Reagan Justice Department, they started suing doctors who refused to work for whatever the insurance company was willing to pay them. So it allows, he continues, insurance companies to pay doctors much less. As long as McCarran-Ferguson is on the books, I see the insurance industry having an incredibly effective tool for fighting Medicare for All. So that leads me to maybe a two-part final question for us, which is one, this view brings up this policy potential or legal hurdle, and allow you to respond to that, but it also leaves me a question, also based on what you've just said, Micah, for folks out there who support this policy, who want to be involved in passing Medicare for all, what are maybe one or two concrete things they could do today that would move the needle? There's a potentially pliable administration. We've got 2 years where that something might be able to happen, even though the administration has sort of signaled that they're not really interested in the policy. What are two things, one, or maybe just even one thing that folks on the ground can do, and then we can wrap up.
Yeah, so maybe I'll take the first piece and leave the last piece to you, Abdul. So, in terms of the comment about antitrust, I think the bigger point here is that the healthcare corporations have won control over the system, and healthcare today looks vastly different than it did 50 years ago. And you now look around in the healthcare system, and it's mostly a patchwork of monopolies and oligopolies, whether it's the pharmaceutical companies or the big hospital systems or the insurance companies. There's all these giant corporations that are dominating the system. And that's not why most of us who went into healthcare want to work in the field. So I think one of the kind of at the core, the moral core of a reform like Medicare for All is trying to take the healthcare system back, to take it back to its roots, to take it back to the point of healthcare is to care for people. And how do you set up a system that makes that as easy as possible? So with that, I'll pass it to Abdul about what folks can do.
Well, look, organize. And I know for a lot of folks, right, that this notion of what does it mean to organize is a bit of an open question. And I'll just say this: find a group of people with whom you want to have these conversations, and ask yourselves, what are the things that we can do to get in the ears of our elected officials, to build understanding and appreciation for what is happening, and to open the doors for more people to come and be a part of this. And I believe that if we are able to engage with each other, share our experiences and our stories, to speak them loudly, and to hold our public officials accountable, that in time, that's what's going to get us there. A lot of folks who believe in Medicare for All are sitting in this moment quite frustrated, and I understand where they're coming from. I campaigned my heart out for Senator Sanders, and he didn't win. I advanced. I was the DNC this year. I sat on the Bernie Sanders, Joe Biden Unity Task Force on healthcare. And even after we'd sort of written our platform, I had the privilege of advancing the Medicare for All amendment on the platform, and obviously it got voted down. And it feels like we're not winning, but I'll tell you what, we are. The industry wants us to think that we've fundamentally lost, that it's over, and that's how they win. So our job is to keep the conversation going, to keep having these discussions with our loved ones, our friends and family, the people we work with, the people in our community, to keep deciding that we're going to spend 20 minutes, 40 minutes, an hour a week doing something to get this in front of our public officials and to get this in front of people who aren't necessarily paying attention. And if enough of us do that, what you're going to see is that the world changes pretty quickly, right? Nobody thought Medicare was going to pass when it passed. It just all came together. So we've got to keep driving this. It's kind of like a freezing point, right? If you move 20 degrees from 60 degrees to 40 degrees, you don't necessarily freeze water, but it's that last 8 degrees that gets you all the way there. And so we've got to keep driving this. We got to keep moving this conversation, and I believe that we'll get there.
Well, we've reached the end of our time, but Abdul, Syed, Micah Johnson, thank you so much for joining us tonight at Home with Literati. And viewers, you can purchase their book, Medicare for All, A Citizen's Guide, at Literati Bookstore, and the link in the chat or in the description below if you're watching on YouTube. And I think we still might have a few copies signed by Abdul, although I think a lot of them got snatched up after they were signed, but we still might have a few left there for you as well. Micah and Abdul, thank you so much, and we hope you continue to stay safe and be well. We hope to have you in the store sometime soon when it's safe to do so, to work on the next book. And to all of our viewers, thank you so much for joining us as well. And we hope you continue to stay safe and be well. And we'll see you at the next event. And take care, all. Have a great night.
Thanks so much for having us.
John, thank you for hosting.
Bye, all.